Okay. Okay. We'll start. You can start.
Yes.
Good evening, everybody. I'm Dr. Vijay Kumar, Chairman, Kerala RSSDI Kerala chapter. I welcome all of you to this episode of Diabetes Crossroads, a CME program of Kerala, an initiative of Kerala RSSDI. It's running successfully for the last 1.5 years. This is, I think, this is the 11th episode. Today, we'll be discussing a very important aspect of diabetes care, role of clinical genetics in diabetes practice. Not so often discussed aspect of diabetes. Genetics, we know that it's a very important, going to be a very important topic in future, but most of us have very little knowledge about the role of genetics. And today that will be discussed by Dr. P. Suresh Kumar, a senior consultant diabetologist from Calicut. He's also the secretary of the Kerala RSSDI. I welcome Dr. Suresh to deliver his talk, and I hand over the session to Dr. Rojit, who is our treasurer, who is our GC member from Calicut. Over to Dr. Rojit.
Thank you, Vijay Kumar sir. So today in our Diabetes Crossroad, we have a very interesting topic, and I'm proud to say our own secretary is state secretary is our speaker, and today's topic is role of clinical genetics in diabetes management. We all know, so the management of diabetes is more of individualized now, and the precision medicine is coming in every disease. And here, how genetics, clinical genetics can help you in recognizing the type of diabetes, which can have some impact on the management of diabetes. To share the experience from his own patients, that is more important. And to introduce Suresh sir, all of you are familiar with him, but to know more about him, I'll just introduce. He has done his MPBS from Calicut Medical College in 1992 and MD from Goa Medical College. And he's a PhD from Calicut University in 2006. And he's currently the secretary of our RSSDI Kerala chapter. And he is an approved PhD guide for Kerala KUHAS, and he is a regional faculty for conducting the PHFI programs, the courses, and he has published many articles in national and international journals, and he delivered talks in various meetings. And recently, API, he was a recipient of Professor Dr. V.C. Matthew Roy Memorial Oration Award of API Kerala chapter, and many awards in his hand. And over to sir for the session. Thank you.
Thank you, Rojit. And thank you. Let me share my slides first. This one. Okay.
Yeah, it's visible.
Is visible now?
Yeah.
Yeah. This one. Okay. Sorry. Yeah. Good evening, everybody. Thank you, Rojit. Thank you, Vijay sir. Anyway, this is on Rojit's insistence that I am presenting this topic here today. I had presented it in Calicut Forum of Diabetes a few months back, 2 months back, I think. And why I am talking about this very rarely talked topic. I don't know whether it has been often talked on the diabetes forums. Not because I am a geneticist. I'm not a geneticist. I'm a clinician. But I thought probably from my experience, what I realized that a little bit more of focus on clinical analysis of patients might probably help us in picking up some of the cases that often are missed. These cases are usually monogenic diabetes. That's why I just decided to talk on this topic here. So what is monogenic diabetes? It is nothing but it's not very rare, but though it is rare, it's not very rare. It is just a non-autoimmune diabetes caused by a single gene mutation and mostly minimally affected by environment and behavioral factors, unlike in the case of polygenic diseases. I'll tell you before going to monogenic diabetes, there are two, diabetes has got two genetic patterns. One is polygenic, where both type 1 and type 2 belongs to that polygenic variety, and the other one is type monogenic diabetes. So that means monogenic means there is a high impact mutation of a single gene. And the prevalence is around 1 to 5% of the pediatric and young adult diabetes population, but it's often insufficiently diagnosed. Though it is 1 to 5%, but it is often misdiagnosed or undiagnosed. And that is basically because of a lot of overlapping of the phenotype with type 1 and type 2 diabetes, both insulin resistance and loss of probably leanness. A lot of factors are there, residual C-peptide. So many things actually are there actually which stands to confuse us in the diagnosis. And ultimately, genetic testing is the only thing that by which we can make an accurate diagnosis. There are around 50 genes are characterized, but most of them won't probably cause diabetes as such. The pathophysiological mechanisms are actually understood better than the other polygenic varieties, because this is a single gene and we know what the gene's function are. So because of that, we know in monogenic diabetes what exactly is the pathology. Whereas in polygenic variety, we won't really know where exactly is the problem. That is one problem. And this actually helps us in, as Rojit, this really makes monogenic diabetes an example of precision medicine in diabetes. So, knowing this will also help us to anticipate, attempt to preempt and prevent or modify the associated clinical features, because especially in syndromic form of monogenic diabetes, we know that once there is diabetes, we know what are the other components that we anticipate to come. So we can weight them, and in anticipation, we can also do something that can help in preventing the severeness or severity of the other components. And another important aspect of this is that by picking up one case of monogenic diabetes, it actually gives us an opportunity to screen for the family as well as for giving genetic counseling. That's very important. And I already told you, monogenic is one highly penetrant variant in single gene. Polygenic means there are several variants of multiple genes with smaller effects, also compounded by the impacts of the environment as well as lifestyle. In type 1 diabetes, maybe you know that it is an autoimmune dysfunction laid over the MHA locus abnormality as well as genomic factors precipitated by environmental triggers. But all these things are not there in monogenic diabetes usually. Monogenic diabetes broadly have got 5 varieties. One is neonatal diabetes, usually developing at below the age of 6 months. MODY, monogenic diabetes of the young. Then syndromic form of monogenic diabetes. Then severe insulin resistance. Then lipodystrophies. These are the other common varieties of monogenic diabetes. Although these subtypes are similar, but there are and caused by single mutations. The critical abnormalities for beta cell function are almost different. They're not the same. Different genes are actually contributing to the ultimate final pathology in the beta cell. Although monogenic forms of diabetes have been described since as early as 1970, it most often are undiagnosed or goes misclassified as type 1 or type 2 diabetes. And because of that, we don't really get to see them as monogenic diabetes, but we see them as type 1 or type 2 diabetes. That's the thing. And the same monogenic diabetes genes can contribute to different forms of diabetes. It could be an early onset diabetes, could be a late onset diabetes. There could be different phenotypical variations in caused by the same pathogenic variation. Even in the same family, you can have different types of phenotypes. That is also a confusing factor that actually prevents us from identifying the cases. That's a problem. And the typical feature of monogenic diabetes, usually young age of onset, less than 30 years, they are mostly either normal weight or low weight, not obese usually, except in the obese insulin resistant variety of obese. And another thing is that absence of islet autoantibodies, except in few rare forms of monogenic autoimmune disease such as autoimmune polyendocrinopathy syndrome, like type 1, that is APS1, or the IPEX syndrome, the immune dysregulation polyendocrinopathy. That is actually an X sex gene mediated thing, IPEX. X chromosome based pathology. Another thing is that usually there will be, unlike in the case of type 1 diabetes, there will be a detectable level of C-peptide even 3 to 5 years after the diagnosis. Usually in type 1 diabetes, that almost become undetectable by 3 to 5 years time. And another thing is that a parent or a sibling with monogenic diabetes, usually if they are, suppose if it is a cascading diagnosis pattern in the previous index case is there, then we know that there is a case. Except in case of rare variety of spontaneous de novo mutations or recessively inherited subtype of monogenic diabetes. Then another feature is additional non-diabetic or non-extra pancreatic clinical features like hearing loss or renal cyst or something like that. And I'll show you some of the sites of the functions of the genes responsible for, or gene products responsible for this pancreatopathy. It could be in the nucleus. Most of them are actually in the nucleus, or some of them could be in the centrosomes, which is responsible for the microtubules. Pardon? The microtubule responsible for mitotic divisions. Another site is actually in the endoplasmic reticulum. There are several genes associated with the proteins in the endoplasmic reticulum, which can go abnormal and develop different types of monogenic diseases, in diabetes especially. Then another thing is the glucose channel, could be a GCK enzyme that is called MODY2 glucose channel, or even in the solute transport channels, like once in the case of thiamine, where you can get the Rogers syndrome, or what you call the thiamine responsive megaloblastic anemia and diabetes and deafness, etc. Then different types of potassium channels can be abnormal, KCN-J11 or ABCC8 mutations, which causes channelopathy in diabetes. And also ultimately in the insulin gene. There are different types of, different sites of their action in the pancreas itself. And similarly, you know that around 50 genes are there, which is actually linked with the glucose metabolism or pancreatic beta cell function. And in the blue, you can see several genes are there laid out here, which has got a bit of overlapping with the other polygenic varieties, that is type 1 or type 2. Some of them may have a milder variety of mutation, that is the it is not a significant, the impact of that gene abnormality is not significant enough to cause diabetes on its own. So maybe there are other genetic contributions also required for them to manifest. So they may be a bit of overlapping. Similarly, you can also see in the clinical features, there are a little bit of overlapping between both type 1 and type 2 diabetes, like early age of onset, that may the similar feature of type 1 diabetes. Another thing is family history in consecutive generation is seen in type 2 diabetes as well. A little bit of predominant in the Europeans, or some form, or some can also have obesity. So there are some overlap, and there are certain applications or calculators. This is an Excel calculator, MODY calculator, where you can actually enter some of the factors and then ultimately calculate the risk for MODY diabetes. There is like age of onset, sex, then whether currently treated with diabetes or not, what is the time to insulin from the onset, then BMI, A1T, current age, then a parent, whether any parent is affected or not, ethnicity, and also other type of syndromic features like renal cyst, deafness, partial lipodystrophy, insulin resistance, or obesity with other syndromic features, etc. These things you can enter and then calculate. If the the risk is around around 25%, that means around a quarter of those people with the 25 risk calculator result is, if it is 25 or more, up to 25% of them can have genetically positive monogenic diabetes. Another proposed simple algorithm for diagnosis of monogenic diabetes is that mostly you have to see that almost 100% of those children infants less than 6 months of age have monogenic diabetes. Then if it is less than 6 months of age, if the onset of diabetes is less than 6 months, then you have to test for neonatal diabetic genes. Suppose if it is between 6 to 12 months, around it's almost 85% is less than 6 months neonatal diabetes. 15% is between 6 to 9 months, and very rarely you get between 9 to 12 months. But anyway, if the child has developed diabetes between 6 to 12 months, again, especially if you test for antibody, if antibody is negative, then test for neonatal diabetes. If antibodies are positive, it could be an early onset type 1 diabetes as well. In the other types like type 1 diabetes or type 2 diabetes, there is the clinical diagnosis is of type 1 diabetes. And if you don't have antibody, that is antibody negative. And if there is a parent to child transmission, that is the parents also is having diabetes, similar diabetes, and there is mild, at least positive C-peptide after 3 to 5 years, as I told you, of onset of diabetes, then test for MODY. Similarly, if your clinical diagnosis is type 2, but there is absence of severe obesity, if the child person is less than BMI is less than 25 or something like that, and if there is a family history of non-obese diabetes, in that case again you test for monogenic diabetes. Similarly, if there are other syndromic features along with diabetes, like deafness or neurological features or renal cyst or genitourinary abnormalities or something like that, then test for syndromic or monogenic mitochondrial diabetes. Then another thing is, you can also sometimes have mild persistent fasting hyperglycemia in a non-diabetic person. In that case, it could be a GCK mutation or MODY2. Then again, you can do testing, but mostly in India, we don't do testing for GCK mutation because one thing, genetic testing is very rare, very sparingly available, and it is costly, and it does not have much of a clinical significance. And from the clinical perspective or complications perspective, it does not have much of a significance in diagnosing that. If you decide to not to treat, that's it. That's the only thing that you have to do. And my own experience, I'll just go through some of our own experience. We had actually sent 86 cases for, that is clinically we suspected 86 cases as monogenic diabetes, and we sent them for testing, and ultimately 11 yielded positive results, that is 13%. I think in most of the studies, we can see that around actually the positivity will be around 5 to 20% is between that. We had 3 neonatal diabetes, 2 had permanent neonatal diabetes, and 1 transient neonatal diabetes mellitus. You can see that these are the mutations which I have given in the brackets. And 3 had MODY1, that is HNF4 alpha MODY. These are the 3 mutations which I have actually described there. Another thing is, we had 4 cases, 4 families of MIDD. We picked up 4 index cases and their family members later. 4 index cases of maternally inherited diabetes and deafness, and all had mutation in the MTPL1 gene, that is 3243A2G transition in the site which is encoding for the leucine transfer RNA. Okay, and 1 case of Friedreich's ataxia, which had a mutation in the FXN gene, which was coding for a frataxin protein. Okay, then another case of suspected case of Wolfram syndrome, then partial lipodystrophy, then the RCAD and PDX1 MODY. These cases actually are awaiting genetic results. We don't know whether they will come positive or negative, given the 13% positivity in those. Anyway, though the HNF1 MODY, otherwise called MODY3, are the most common MODY other than MODY2, we had actually we mostly had only HNF4 alpha MODY, and we didn't have even a single case, though majority of them, almost in the ratio of 3:1 is the international reports of MODY 3 to MODY1. But here we had only MODY1 case. We did not have even a single case of MODY3. Anyway, we don't know why. Maybe we don't know whether it is a peculiarity of Indian content, Indian population or not. We don't know. Let's talk about neonatal diabetes mellitus. This is also termed congenital diabetes or diabetes of infancy. The monogenic diabetes occurring under the age of, mostly under the age of 6 months in 88 to 85% of cases, and 15% of cases can have it between 6 to 9 months already told you. Prevalence is between 1 in 690,000 to 260,000 live births. It could be of transient or permanent variety, or some of them could be even syndromic form. And 50% are permanent and 50% are transient neonatal diabetes. And up to 80% it could be de novo mutation. And up to 80% you may not have a parental history of this thing. That is the sometimes it can be confusing, and or you may not suspect it. The clinical features are usually intrauterine growth retardation, failure to thrive, polyuria, severe dehydration, rarely sometimes birth defects or neurological disorders like Down syndrome. That is developmental abnormality, or epilepsy, neonatal diabetes syndrome, like that. Then there are over 20 non-genetic causes for neonatal diabetes, and mostly 50% of them are caused by the channel mutation in the KCNJ11 or ABCC8, and the remaining are caused by 6q24 or insulin genes. And most of the 60 to 70% of the transient neonatal diabetes is caused by 6q24 gene mutation. And when to suspect a neonatal diabetes? When an infant presents with the insulin-dependent hyperglycemia. That is, usually sometimes you can have, if you had infused plenty of glucose in the mother, you can have transient hyperglycemia. In sepsis, you can have transient hyperglycemia. If you had used steroids, you can have transient hyperglycemia in infants. Not like that. They usually disappear within a matter of 1 week time. It will last 3 to 7 days. But if the child has got persistent hyperglycemia above 250 and which lasts for 7 to 10 days, then, and if it only responds to insulin, you have to suspect NDM. But if the blood sugar exceeds 300 milligram any point of time, even without regardless of the time course, you have to suspect NDM. And also in any infant requiring insulin below the age of 6 to 12 months. How do you treat? If they are caused by, if the NDM is caused by channel mutation or channelopathy, then you can manage them with sulfonylurea, but others will require insulin. Sulfonylurea, identifying the channel mutations will be, and treating them with sulfonylurea early on. So it is very important because this can prevent or delay the neurodevelopmental abnormalities, because the receptors for sulfonylurea are not only there in the pancreas, but also in the brain and nervous tissues are also there. So that mutation can be there also. So you have to suppress them as using sulfonylurea. So that may be that. If you use only insulin to treat them, then this problem will be the precipitation of the neurodevelopmental abnormalities will be there. That is the importance why you have to use sulfonylurea in them. That's it. And this is the first report on the clinical and molecular characterization of neonatal diabetes and monogenic diabetes syndrome from Asian Indian children, reported from India. This was published in 2013 by Dr. Mohan and a group, and I was also a co-author of the article. This was published in Clinical Genetics, and a highly indexed journal. This actually, what happened is why I became an author is because of the 16 cases or from the 10 families, 3 of them were mine. That's why I also was a part of the authors. Another interesting thing is this one was the first reported case of insulin gene mutation from the country. This was reported by the Amrita team. This patient was originally mine. Actually, I had sent these patients to Dr. Unikrishnan suspecting a neonatal diabetes for checking, because those days in 2004 I had sent those days actually genetic testing was not available in India. They had to send it to Exeter in UK. Then I talked to Dr. Unikrishnan and he said now he can get it done from UK, Exeter. So I sent the case there. But when they published, they forgot my name. Anyway, that is the first case of insulin gene mutation report from India. And from this, you can see there are several genes responsible for the monogenic diabetes and here, neonatal diabetes. Here, most of them, majority of them, around 80% of them are caused by the first 4 genes. The first 2 are responsible for the channel mutations, KCNJ11 and ABCC8, and the other 2, 6q24 for the transient neonatal diabetes and insulin gene. And the 3 KCNJ11, ABCC8 and insulin gene mutation can cause both permanent and neonatal diabetes. And the first 2 things can respond to sulfonylurea, or they may need sulfonylurea as a matter of fact. And others, most of the others can only be managed with insulin. And you know that another thing which I was referring to was the channel mutations, like solute transport mutations, channel mutations. One of such is the thymine transporter mutation, where you may see, apart from diabetes and deafness, you can also see thymine responsive megaloblastic anemia, where you also have to use thymine for management along with infection. Then permanent neonatal diabetes, one of our cases, I'll just tell you. This is a baby. This photo was of when the baby was 6 months. But this baby actually was presented at the when she was 2 months old. He had it's a male child. His birth weight was 2.5 kg, and blood sugar, initial blood sugar was 235, and A1C was 7%. This child was actually referred to PVS hospital under Dr. Krishnan Gutti. He was a pediatrician, neonatal. This case was actually having neonatal hepatitis and sepsis, and I was asked to titrate his insulin. That's why I was called in to the ICU to see this child to titrate its insulin for diabetes management. Then I realized that it is a neonatal diabetes, and we sent his blood for genetic studies. On my own, we sent it to ICMR laboratory, and we later, after some time, took around 1 year or so for the genetic results to come. It was a mutation in the ABCC8 gene. And after we got the genetic study result, we switched him over to glibenclamide. And this is the child in 2021 when he was 13 years of age. He's there. Now he's on half tablet of Dionyl twice daily. And later he actually showed some failure to thrive. Like there is lower growth expected than for his age. His growth hormone was low, IGF-1 was low, C-peptide was low, and vitamin D and vitamin B12 also was low. Maybe there are some malabsorption as well. And but his father also had some failure to thrive when he was a child, but later he caught up with this growth. And because of that, we actually reassured the child and the parents. But for doubly making sure, I sent the child again for a second opinion to Dr. Vimal from him. He also said, like, no, he reassured the child and sent them back. And this is his sugar parameters. I think we tracked the sugar from 2014 to 2022. You can see here, only twice or thrice he had high blood sugar, and that too while he was on sulfonylurea. As the blood sugar was been too normal, they thought probably his diabetes has disappeared, and they stopped the drug, and its blood sugar shot up, and again restarted on drug, and again he remained almost like in a straight line. You can see here. This is the beauty of this case. Otherwise, he would have been destined to be on insulin forever, and would have also had several other developmental abnormalities as well if he had not started sulfonylurea. This is a case of TNDM, that is transient neonatal diabetes. This child was, young man was actually grandson of a doctor whose wife was my patient. And he was a BR student at Chennai. He was brought to me when he was 17 years old. He had a history of diabetes detected at first year of life, but it's actually disappeared after some time. When he was brought to me, just 5 days before that, his fasting blood sugar was 317, and his A1C was 12.5, and he had a normal BMI, normal BP, euthyroid. His antibodies were negative, and C-peptide was fasting 0.69, and random was 1.61. And immediately, I started him on Dionyl half BD, realizing that it could be a TNDM only. Then I sent his blood for genetic testing, and it came positive for ABCC8 mutation, gene mutation. Now we have ABCC gene mutation. One is a TNDM, and the other one is a TNDM, the same gene. Okay, there is two different phenotypes in the same gene. That's what I was telling you. And here again, the blood sugar, tracking. You can see here. First, initially when he came, this was his result. Then after starting on sulfonylurea, his blood sugar became normal for quite some time. From 2018 to 2022, till 22, he was normal. He had almost near normal blood sugar. This is the time when he was undergoing his BR examination. And because his blood sugar was absolutely normal and he was only on a half tablet of tablet, he thought probably he can skip the medicines, and he skipped medicines and his blood sugar shot up. Again, he came back to me, restarted on medicine, blood sugar became normal. That's it. Then talking about Modi, the typical Modis. So Modi actually was named by Fajans and for a type 2 diabetes-like presentation in young people with the autosomal dominant pattern of inheritance. And now it was actually earlier called Modi 1, 2, 3 by number. Now they are renamed as with the abbreviation of the genes responsible for the mutation and with the suffix Modi. So it will be SNF1 Modi, 1A Modi, or SNF4A Modi, GCK Modi, etc. etc. There is a new nomenclature. Prevalence is around 1 to 5% of youth onset diabetes, 1 in 10,000 in adults and 1 in 23,000 in children. But GCK mutation, Modi or Modi 2 are very much more common than the others, almost 1 in 1,000, but usually goes undetected in at least in Indian population, but in UK population and all, it often they pick them up. And there are around 15 specific genes responsible for this Modi, but 3 of them are being recommended for to be deleted because the prevalence in general population also is almost like in the case of Modis, so they have to be deleted, and the 12 remains now. And but every time there is one new like 1 or 2 years, in 1 or 2 years, one new Modi will be added to this numbers. Anyway, there are around 15 genes which is responsible for glucose metabolism disorder, but not all cause monogenic diabetes. These are the schematic representation of the glucose metabolism and the Modi genes associated with them. You can see here, it could be in the glucokinase gene, GCK mutation, that is Modi 2. It could be in the channels, potassium channels, AITP channels, either potassium inverted rectifier 6.2 or in the SUR1. It could be in the insulin genes. It could also be inside the nucleus. The mutation could be in a sequence of nuclear factors which are responsible for the proteins and secondarily responsible for the beta cell or even the pancreatic growth, differentiation, or probably development. So any mutation on any of this thing can cause diabetes. These are the 15 genes which I was talking about. In that, the 3, that is Modi 7, 9, and 11 are recommended to be deleted. Other 12 remains. And you can see that the first 3 actually, the Modi 1, that is HNF4 Modi, GCK Modi, and HNF1 Modi actually contribute to around 80% of the Modis. And the remaining 9 actually constitute only around 20%. Okay. And the first and third Modi can be managed with sulfonylureas. Second, you don't need any treatment as such, except during specific cases of pregnancy. And majority of the other Modis can also be managed by oral hypoglycemic or sulfonylureas, and some of them or most of them later progress to the stage of insulin requirements. That is there. This is an HNF4 alpha Modi. For example of a HNF4 alpha Modi. So we had 3 other cases. This is one. This actually, why I bring it here is because of the interesting fact that this young man was actually brought to me because of one reason. Because he actually attempted suicide by injecting insulin overdosage of insulin, because he was diagnosed as type 1 diabetes at the age of 17, and he was put on insulin multiple dosage, and he got depressed with that, and he'd want to commit suicide. Actually, what struck me was his mother was also having diabetes since the age of 15. When I took the family history, I found that his mother also had diabetes, and she was elsewhere diagnosed as type 1 diabetes and was on insulin. His father was also diabetic. Like usually the typical type 1 diabetes will not have this sort of family history. And then what I thought was, I reassured him and I took him off insulin, and I started him on glycoside. His initial blood sugar was, when he presented, was 172 fasting, 264 pp, A1C 7.8, GAD antibody, IA2 antibody negative, ketone was negative, and we know that he is not type 1 diabetes. So with glycoside, after putting on glycoside, I sent his blood for genetic analysis to rule out Modi. And this is his results. You can see that on chromosome 20, this is a DNA location and the other positions, amino acid change and exon positions of the mutation. That is mutation for HNF4 alpha. And this is blood sugar profile over a period of 3 years from 2020 to 2023. This is the initial blood sugar. After starting on glycoside, his blood sugar became normal. It remained normal for some time, and again he thought probably he got cured and he stopped medicine, and then his sugar shot up. Again, blood sugar became normal. That is it. So he was having a very smooth blood sugar control over the years, and he will remain so probably for the rest of his life, hopefully, and probably, if God willing, he won't go into insulin. Then, and he was very happy also after that. He was cured of his depression as well. That's the most important blessing of that diagnosis, actually. Then GCK Modi. GCK Modi is supposed to be the most common monogenic diabetes. The prevalence is 1 in 1,000 in the white UK population, but in India, we don't pick up so many. Usually, it does not require treatment except during specific case of pregnancy. I'll tell you why. Why we don't treat is because there is no increased risk of vascular complication. Treated cases. When they compared treated cases of Modi 2 with untreated cases, there was no difference in the vascular complication. That is why there was no treatment required. Okay. And another thing is that it carries the same risk as normal population or development of type 2, and hence you can sometimes, most often, you can see coexistence of these two things. So confuse it. You may usually miss. Suppose if there is maternal GCK mutation, you can see fetal macrosomia. Why? Because in the threshold in the mother's blood is high for blood sugar, and this high blood sugar enters the fetal side, and it causes increased insulin secretion by the fetal pancreas and causes fetal macrosomia. Suppose if the reverse is there, if there is no maternal GCK mutation, but the mutation is in the fetus, then you can see the reverse. That is, there will be growth retardation because the fetal threshold for glucose is high, insulin secretion for is high. Naturally, the insulin secretion, insulin is a growth hormone. Because of the lower insulin secretion, there will be growth retardation. But if there is mutation in both fetus and mother, growth will be normal. And now there are non-invasive genetic testing, which is possible in the cell-free DNA in the maternal circulation. We can pick up GCK Modi. And another testing method is by serial fetal ultrasound. You looking at the fetal growth, you can say, suppose if there is excess growth of fetus, and if there is maternal GCK mutation, you can know that there is no mutation in the fetus. If there is growth retardation, and there is no mother GCK mutation in the mother, then it could be a fetal de novo mutation or probably a paternally inherited GCK mutation. Okay. Then if the fetus grows normally, you know that both mother and the fetus also has got, the fetus has inherited the mutation from the mother. And this is a lady, actually, she's a professor in a college. She had 20 years of type 2 diabetes, came for control of blood sugar, just because her fasting blood sugar always remained high. She had a strong family history of diabetes on both mother's and father's side. One of her younger sister had gestational diabetes. Her fasting blood sugar during pregnancy was high. That is what the family history gave. That gave me the clue as to this diagnosis. Fasting was 149, but PPBS was 167. And this is her blood sugar profile. You can see that the green lines are showing fasting, and her fasting never came down below 140. Only 140 was 130. It's always above 140. PPBS, that is drawn in orange, actually goes lower than fasting most of the time. And that was a, and I also did her AGP, ambulatory glucose profiling, once, and I found that after 10 o'clock at night, her blood sugar, if she had 8 o'clock or something, after 10 o'clock, her blood sugar remain in a one straight line, almost straight, no dipping or doing. That shows that there is a threshold, static threshold for fasting at that particular level. And now syndromic diabetes. We know that it is possible to for diabetic patients to have multi-system syndromes as a result of single gene defects, where diabetes could be the first manifestation of the multi-system syndrome. And this additional non-autoimmune extra pancreatic features are the ones that gives you the diagnostic clue for syndromic diabetes. Prevalence is around 90% of all patients suspected of MODY. And that is 90% of MODY can have syndromic diabetes. But among the monogenic diabetes, syndromic diabetes, almost half of them will be maternal inherited diabetes deafness. A third will be the RCAD, that is renal assistant diabetes, then or HNF1 beta MODY. Then other syndromes could be Wolfram syndrome, insulin receptor gene mutations, etc. And majority of the syndromic diabetes may not show typical complete clinical picture. All the other extrapancreatic feature may not manifest. So you may sometimes miss the diagnosis as well. So this is a MIDD case. I'll just tell you a brief MIDD. MIDD was actually described since 1992, first in 1992, as a result of mitochondrial DNA mutation. Prevalence is up to 3% among the diabetic population. But most often, almost always misdiagnosed as either type 1 or type 2 diabetes. And the clinical features include diabetes, low BMI, sensory neural hearing loss, and macular pattern dystrophy. And usually diabetes onset will be third or fourth decade, unlike in the other case of MODY, which is having an earlier onset of diabetes. Here, hearing loss is usually diagnosed before diabetes, and it is usually bilateral and sensory neural, and gradually progressive it is. And in the retina, you can sometimes see retinal or macular degenerative changes, but only seen in a quarter of MIDD cases. And a similar proportion of patients can also have other system problems like cardiomyopathy, proximal myopathy, and nephropathy, or even central neural dysfunctions like Melas-like syndrome or cerebral atrophy, dementia, or something like that. And it is important to differentiate these cases early enough, institute correct treatment. Otherwise, they can progress into system abnormalities and the system. This is one report. This is very important. This is actually published by me as the first author. All the cases reported in this case report series are mine, my center. This is the largest ever reported case series from India so far. And before this, there was only one single case reported on MIDD from India. That was from UP, a single case of one lady with MIDD was reported. After that, this is the largest case and but largest case. We included 3 index cases and 5 of their relatives. Total 8 cases in this series. These are the clinical features of all my MODY cases, as for MIDD cases. The fourth one is a recently picked up one. The fourth one is a young lady doctor who was diagnosed as diabetic since the age of 18 and was on type 2 diabetes and put on glimepiride. She did not have hearing loss, and notice no history of family history also there. And she was not sure whether there is anybody having mild hearing loss in the family, but she did not have any hearing loss. But most of her maternal side family members had diabetes. Mother, sister, maternal grandmother, maternal aunts, etc. all had diabetes. But in the other 3 cases, you can see all the other 3 were diagnosed as type 1 diabetes and put on insulin. Age of onset was around second or third decade. And age at presentation in the second and fourth cases in 40s, fourth decade. You know that hearing loss was there actually, which preceded diabetes in all the 3 first cases. Family history is strong on mother's side in all cases. BMI either normal or low. C-peptide was low in all the first 3 cases, whereas in the second case it was a little bit on the low normal level. There is a random C-peptide actually. Autoantibodies were negative in all 4 cases. There were some conduction abnormalities in the ECG of second and third case. There is some pigmentary changes in the second case. There is no nephropathy. That is the clinical parameters of all my cases. This is electropherogram, which shows the mutation. The arrows you can see here, arrows indicate the site of mutation at the MTTL1 gene for the 3243 A to G transition in the mitochondrial DNA. Okay, that's it. The important things to remember in MIDD is that you better avoid sulfonylurea because it can precipitate beta cell worsening, beta cell failure. Similarly, metformin may cause lactic acidosis cases with severe heteroplasmy. That is, if the brain heteroplasmy, and I don't go into details of heteroplasmy, all these things, that is another topic for another talk actually. If the heteroplasmy level in the brain is more than 70% or so, people usually present as MELA syndrome. If it is above 60% or so, sometimes these people can easily get precipitated for MELAS by using metformin, like that. So it's better avoid metformin in such cases. And see, the thing is, these are the two most commonly used anti-diabetic agents in diabetes. If you misdiagnose them as type 2 diabetes, you use sulfonylurea and MELAS, metformin, and sometimes even precipitate MELAS and other system abnormalities. And the ray of hope actually now is the recently launched anti-diabetic called imeglimin, whose mechanism of action is specifically on the mitochondrial bioenergetics. And there is so far there is no report of its specific, effect on this particular syndrome. But I have started using in all my monogenic diabetes cases, MIDD cases, and in one Friedreich's ataxia case, and I found a little bit of response, but there is no published report on this particular drug efficiency on this cases anyway. As of now, insulin and mitochondrial agents like coenzyme Q, L-carnitine, lipoic acid. I think somebody is talking. Can you all mute your things, please? I'll just go ahead.
You can mute from your system. Right.
I'll just see whether
Vijay Kumar,
okay.
okay.
Can you hear me now?
Yes, sir. Yes,
Yeah.
yes.
Okay. Thank you. So that was it. Now, as of now, insulin, mitochondrial agents like coenzyme Q, L-carnitine, lipoic acid, and antioxidants with mitochondrial tropicity like vitamin E, thiamine, etc., are the mainstay of treatments as of now. Right now, coming to Friedreich's ataxia. The Friedreich's ataxia is actually caused by a defect in the gene labeled FXN gene, which codes for the frataxin protein. And the prevalence is in actually 1 in 40 to 50,000. But the thing is, diabetes with Friedreich's ataxia is actually 1 in 120,000 to 1 in 150,000 only. So rare it is. All Friedreich's ataxia cases may not develop diabetes. The inheritance is autosomal recessive, and about a third only develop diabetes in Friedreich's ataxia. The symptoms and clinical findings associated with Friedreich's ataxia usually results primarily from the degenerative changes in the sensory nerve fibers at the point where they enter the spinal cord in the dorsal root ganglia. And because of this, there will be secondary degeneration of the nerve fibers that travel across the spinal cord, leading to deficiency of the sensory signals to the cerebellum, which coordinate the voluntary movement. So because of that, there will be both sensory ataxia as well as cerebellar ataxia in this case. But this young lady, which presented to us at 28-year-old, when she was 28 years old, she was earlier diagnosed elsewhere as a sensory neuropathy with ataxia or sensory ataxic neuropathy. She was brought by her father, who was my patient. She was born out of a consanguineous marriage. And she was on metformin, which is not very good for this Friedreich's ataxia cases, which is also having an impact on the mitochondria. and sulfonylurea, also on DP4 inhibitors and neurobioport. Her nerve condition study showed her motor nerves were normal, whereas sensory nerves, none of the nerves tested could be elicited, suggestive of sensory polyneuropathy. And nerve biopsy showed features suggestive of hereditary motor sensory neuropathy with the axonal form, with mild reparative process, not severe reparative process, as in the case of demyelinative disorders, where you can see some sort of what you call that onion peel appearance, recurrent demyelination and repair, remyelination, demyelination like that, that causes onion peel appearance. It's not been seen there, and there is no inflammatory components as well. So we know that it was hereditary neuropathy. CT had showed mild brain atrophy, and she had a tiny PDA with the left-right shunt, and her ejection fraction was normal. Sometimes you can even develop a cardiomyopathy. But here her ECG showed some conduction defect, conduction abnormalities, which actually caused her to be admitted in the ICU in a cardiology department for the management of acute coronary syndrome. But they corrected the diagnosis on a second visit and put that it is only conduction abnormality and it is not acute coronary syndrome. And this we sent her blood for genetic analysis with a clinical suspicion of Friedreich's ataxia. And because of that clinical suspicion, they specifically tested for this sequence of mutations, specifically in the Friedreich's ataxia gene. And there was a triple nucleic acid repeat, which is in excess than what is required, found on the Friedreich's ataxia gene, which was confirmed by the triplet repeat PCR, prime PCR technology, which confirmed the mutation. And the diagnosis was confirmed as Friedreich's ataxia. And you can see her blood sugar profile. This was her initial blood sugar, 415 and 380 when she presented. We started her on insulin. Then when hemoglobin was available in the market, I also started her on hemoglobin, but she could not tolerate hemoglobin in the beginning due to edema, which I don't know whether it was really due to hemoglobin or something else, but later she tolerated. And she was also put on L-carnitine, vitamin E, coenzyme Q, and neurotropic vitamin combinations. And you can see here, her blood sugar significantly improved, almost flattened like over a period of time. Her A1C also flattened. Her some of her symptoms of ataxia also stabilized actually. It's not improved. We don't know whether it improved. They say slightly improved, but I think it could be it's only stabilized for the time being. Ultimately, it will definitely worsen, and she will succumb. No doubt about it, because she's been having this disease for quite some time. It's a rare form of monogenic syndrome, and it actually comprises diabetes insipidus, diabetes mellitus, optic atrophy, and sensory hearing loss, and also some other neuro and endocrine abnormalities. Prevalence is 1 in 1,60,000 to 1 lakh. This is Wolfram syndrome. Okay, I'm talking about Wolfram syndrome, another monogenic syndrome. 1 in 1,60,000 to 1 in 7,70,000. It's very rare. Probably you can see that around maximum 200 or 50 cases been reported world over so far. Again, inheritance is autosomal recessive. The highest prevalence is seen in Lebanon. Around 5.5% of all juvenile onset diabetes are supposed to be due to Wolfram syndrome, due to high incidence of consanguineous marriage among Arabs. The two types of Wolfram syndrome are type 1, that's the most common, more than 85% are type 1, caused by the WFS1 gene mutation. And the type 2 is extremely rare, caused by CISD2 gene mutation. But that is not an incomplete Wolfram syndrome. Wolfram syndrome 2 is an incomplete Wolfram syndrome actually, because they don't actually exhibit diabetes insipidus, and even optic atrophy are less frequent than Wolfram syndrome 1. But thing is, Wolfram syndrome 2 usually may have severe peptic ulcer disease with the bleeding disorders associated with the diabetes and other syndromes. Okay. This is one girl child referred to us by an ENT surgeon for glucose management. Her random C-peptide was 0.5. GAD antibody, IA2 antibody, and zinc transporter rate antibodies were all negative. She had undergone a cochlear implantation recently for her sensory hearing loss, and her genetic results are awaited actually. It's not yet available. But now we have made a provisional diagnosis that non-autoimmune type 1 diabetes with sensory neural hearing loss. Probably part of a monogenic syndrome. We don't know whether it is Wolfram syndrome. Without getting the genetic result, we can't declare it as Wolfram syndrome. Anyway, then another case which we have is a partial lipodystrophy. Then actually, 60-year-old lady brought to me with 19 years of duration of diabetes. She was put on insulin because of her high fluctuating blood sugar. She was diagnosed as insulin recurrent type 2 diabetes with brittle diabetes. She was on insulin for 15 years. Initially, for some 4 years, she responded to blood sugar, but without going into ketoacidosis, because of that, it was diagnosed as brittle type 2 diabetes. And she had widely fluctuating blood sugar. She also develops recurrent hypoglycemic episodes whenever her insulin dosage was increased to control blood sugar. She goes into hypoglycemia. Because of that, she develops frequent episodes of fatigue. She was having a normal BMI. BP was slightly high. And she had a past history of hyperthyroidism treated with radioactive iodine. She also had hypertension. Dyslipidemia was under treatment. She had a history of infections like chickenpox, chikungunya, etc. She also had a history of two abortions. There was no history of gestational diabetes, no PCOD, no fatty liver, facial trauma, dental infections or surgery, or retroviral therapy, antiretroviral therapy, etc. which are usually responsible for localized fat atrophy or lipoatrophy. Family history: parents did not have diabetes, but 2 brothers had diabetes. There is no family history of lipodystrophy, ischemic heart disease, thyroid disease, or some other complications. No smoking, no alcohol, nothing. Her history of lipoatrophy, how it started. She had transient loss of fat at the site of injections, insulin injections, and also in the breast at the age of 50 to 51, which disappeared spontaneously after some time. And there was a small depression which started at the age of 52 on right cheek and then spread to the other cheek as well. And there was loss of fat on the left cheek also by the next year. Then it's actually spread to both upper limbs with the thinning of the upper arms with the sparing of the lower limbs. This is a history of lipoatrophy. This was her parameters: blood parameters, high blood sugar, fasting and postprandial. TMT was positive for coronary artery disease. She had coronary artery disease. No PAD. She did not have nephropathy. She had mild to moderate diabetic nephropathy as well as mild NPDR. Her antibodies were negative. Antithyroid antibodies were also negative. C-peptide was low normal, even after 19 years of diabetes. Ultrasound thyroid showed MNG, multinuclear goiter, then multinodular goiter. Then ANA was negative. Complements C3, C4 were negative. Other responsible factors for lipoatrophy. Leptin levels could not be tested. That's in 2012. She came to me. Actually, those days it was not available. Later it was available. It was very costly, 6,000 to 10,000 rupees or something like that. We didn't, and patient refused to test that because of the high cost. She didn't want to go for it. After she had already undergone several costly tests, that's why she refused to do that. This was her blood sugar profile over 7 years, 6 to 7 years. You can see that never, except probably once or twice, her blood sugar came to normal levels. Always it was very high. Either sometimes she goes into hypoglycemia, severe hyperglycemia, etc., etc. And A1C is somewhat closer to 7 goes only once. Otherwise, it's always high. And her ambulatory glucose profile, you can see wildly fluctuating blood sugar. But the important thing is early morning, between probably 6 to 10, her blood sugar was either normal or low. That is the only time when she develops fasting hypoglycemia. But whenever she takes food, anything she takes, her blood sugar shoots up. Even if you give insulins, but if you increase her insulin, after some time she goes into severe hypoglycemia. That is what most often sometimes it happens. Postprandially, you can see some of the tracings shows hypoglycemia here and at night as well. So that was her ambulatory glucose. This was her photos which was available with me. This later photos which was taken by me. This was when she was 25. At SICO was normal, and at 29 she had a mild dimple-like depression here in the cheeks, but it's not prominent. At 66, I took the photograph. Then I thought of like in a publishing case. You can see here severe loss of fat from the both maxillary area. Here you can see here. And we took an MRI of her face. On the left-hand side, you can see the patient's MRI, where there is a total loss of fat on the maxilla, right maxillary side. Left maxilla, there is some fat. This is for comparison, this is a normal facial MRI. You can see fat in the white. There is normal, equal, symmetrical fat on the both sides. Here it is asymmetrical fat atrophy here. That is it. So she was treated with insulin. Then saroglitazar is a dual agonist. Initially, I started around like pioglitazone. Then I switched over to saroglitazar, thinking that might give some results. And DPP-4 inhibitors, antihypertensive statins, aspirin, etc., because she had CAD. And her blood sugar remained throughout brittle. Metreleptin is actually the drug of choice, injectable metreleptin, which was not available in India. And if it is available, it is very costly also. So we could not afford that. And we did not give it. Anyway, ultimately, these were my cases, some of cases. Now, what I did was, after seeing so many cases, I just analyzed the clinical factors associated with this monogenic positive cases and negative cases to find out whether there is any specific features that might probably give you a clue other than genetic testing, whether to see whether it is monogenic diabetes or not. You can see the parameters here: age of onset, BMI, body fat, visceral fat, waist circumference, skeletal muscle, BMR, systolic BP, duration of diabetes, cholesterol, and then other lipids, OT, PT, ESR, GFR, renal parameters, albumin creatinine ratio, C-peptide, A1C, etc., etc. Of this, what is marked in red is the one that has got some statistical significance when compared between the monogenic group as well as the non-monogenic among the clinically suspected monogenic. These are gene positively tested for positive. These are tested negative, but clinically suspected cases. You can see there was significant difference between these two groups in the age of onset. Usually, this all cases belong to less than 28 years. BMI were less than 23 in all cases. Visceral fat less than 6. Waist circumference less than 80. Then triglyceride less than 150. Whereas in the other case, it was almost around 150 to 220 and above, like that. VLDL was normal. OTPT were SGOT was less than 25. CPT less than 30, like that. Most of them, and albumin creatinine ratio less than 15. There is no nephropathy in any of these cases so far. C-peptide was also less than 1, except in the latest cases, case of MIDD. There's 1.4 random C-peptide. These are fasting C-peptide actually. The other one was random C-peptide. So when you look at this fasting C-peptide, all were less than 1. Where in the other cases, though it was low, it was above 1. That is it. So anyway, these are some of the clinical parameters. If you have a combination of many of these parameters in one single case, whom you suspect clinically as monogenic diabetes, you can send them for genetic testing. Otherwise, it is better not to, because the positivity is very low, around 15 to 20%, 5 to 20% positivity in clinically suspected cases of monogenic diabetes. And it is a rare resource. Genetic testing actually is rarely available, sparingly available. So it has to be judiciously used. But clinical suspicion, high index of clinical suspicion is warranted in picking of cases. So in summary, monogenic diabetes is not so rare, but high index of clinical suspicion is required for diagnosis. Clinical differentiators are with other types of young onset diabetes are very few. Only 5 to 18% of clinically suspected cases turn out to be positive. Genetic testing is costly and sparingly available. Accurate genetic diagnosis of monogenic diabetes is crucial for patients since it helps in optimizing the treatment and preventing complications. Additionally, accurate monogenic diabetes diagnosis leads to better familial risk management and clinical course prediction. Monogenic diabetes provides an example of translating research findings into clinical practice that improve diagnosis and quality of life. And improvements in sequencing technology are actually increasing opportunities to diagnose monogenic diabetes, but still challenges remain. So that was all about this clinical genetics and diabetes practice by me. Thank you very much for the patient hearing. Thanks a lot.
Thank you, Suresh sir, for a brilliant presentation. And
Thank
the
you.
beauty of the presentation is that all the cases sir shared here is from his own experience and his own single center. So the enthusiasm, the documentation and analysis of all the cases was excellent and inspiring for all the young generation how to put research into your practice. Thank you, sir. And most of the cases sir described is, even though it is rare, it was life-changing diagnosis, I think.
Yeah.
So thank you so much. And we have a few questions from the participants. One is, do you ask for MODI panels or clinical exomes in practice by Matthew Johnson?
No. Actually, I see we first do the new generation sequencing, and then suppose we don't see Matthew John, hi. We suppose if that turns out to be negative, and if we suspect say specific syndromic diabetes or something like that, then we ask for exon sequencing. That's what we usually do.
And one question from Arjun. So first is the comment, sir, brilliant presentation. Could you please highlight how the patients are doing currently on imiglimine?
Yeah, that's what. Actually, it's only probably nearly 1 year or so, no? But most of my patients are doing well. But I don't usually use imiglimine in other type 2 diabetes cases or something like that, unless I suspect some mitochondrial involvement. They are all doing well, Arjun, mostly.
That's what I wanted to know, sir, whether the response is much better than starting in the type 2.
Yeah, the most interesting thing is actually this not only imiglimine. I have not given imiglimine alone in any of these cases. Mostly I have given mitochondrial tropic agents along with imiglimine. So we don't know really whether which one is actually helping them. That is there.
And one more question is cost of genetic analysis of MODI. So everyone wants to know the cost and how you are doing.
Probably cost varies, but mostly for me, it was around 16,000 rupees costing per test for only new generation sequencing. But if you need exon sequencing later, specific exon sequencing, then we have to pay more.
Being done by Dr. Mohan and also in Vellore.
Yeah, in Vellore. Yeah, Vellore and the ICMR lab with Dr. Mohan.
ICMR.
Yeah.
MedGenome and the Newberg also doing it.
Yeah, there are several laboratories who have come up with this this thing. I don't know. I don't usually. I send it to ICMR lab.
Vijay Kumar sir.
Thank you, Dr. Suresh, for an excellent presentation. Actually, I was completely involved. We are all involved in the presentation, and we bow before you for your excellent work, dedicated work for several years, and presenting it in a very lucid way so that all of us can understand this very difficult topic. Thank you, Dr. Suresh, for an excellent presentation.
Thank you, sir.
Hello, sir.
Yeah, I know. I presented because that might probably help many clinicians in picking up cases.
Sure. Definitely, it will be helpful for clinicians, and also it should be an impetus for the youngsters to do more research on this common problem, diabetes. Okay.
Exactly.
Dr.
Hello, sir. Sir, Jasim.
Jasim,
hello. Sir, ഇപ്പൊ ഈ മോഡി ജനറ്റിക് അനാലിസിസ് അത് പിന്നെ ഒരു ഇപ്പൊ കോമൺ ആയിട്ടുള്ള 3 എണ്ണത്തിനാണോ ഇടുക അല്ലോ പാനലായിട്ടാണോ?
There is actually around 16 genes in the panel they do it in a single.
അപ്പൊ ഒറ്റ പാനലായിട്ട്.
Yeah, and
മോഡി 2 rule
will be included in that. And if that is negative, then if you give them sufficient syndromic diabetes or specific syndromic diagnosis, clinical suspicion, then they'll go for exon sequencing as well.
Okay. Thank you.
One question from Dr. GT. Sir, what about the prognosis of these monogenic forms? How it differs from type 2 or type 1?
The most important thing is that the monogenic diabetes, I'll tell you, for channelopathies, if you clinically diagnose or genetically diagnose them and start them on sulfonylurea, I already told you during the initial clinical presentation that if you start them on sulfonylurea, this can help them in delaying or actually preventing the neurodegeneration as well as other system degenerations. Because these receptors are also, their mutations are also there in the other systems. One thing. Then another thing is that otherwise all these things will be destined to be dumped to take multiple doses of insulin. And usually they will not respond well to insulin. Even if you put them on insulin, there will be a brittle nature will be there. Will not be the response will not be as good as in typical case of type 1 diabetes. So that is another problem. So we can save those people from going into lifelong insulin injections and their complications. And lifespan also most probably I think will be better because when their blood sugar level is better controlled than with insulin, naturally they'll have a better life and lesser incidence of complications.
Another question from Dr. Shahana. This is a comment. Excellent presentation, sir. We do see cases diagnosed as type 1 diabetes, but with subsequent testing of C-peptide raised up to even 1.5 or more.
Yeah.
Could you explain on the same, sir? How do we then classify these cases as?
That's what actually type 1 diabetes. Usually, there is an irreversible and complete loss of beta cells, either due to autoimmune or an idiopathic variety. In any case, usually, at least by 3 to 5 years, mostly there will be at the level of around undetectable range. Understood? No, if it is a near normal or low normal or even detectable above 0.6 C-peptide level, then naturally we have to think of other causes. It is unlikely to be type 1 diabetes, and that is one hint that gives that it could be a monogenic diabetes or other forms of diabetes.
Any comments from Dr. Prashant?
Marty John is there.
Bhargavan sir is there.
Bhargavan sir is there. Yeah.
Any comments, sir?
Please.
Thank you, Suresh Kumar, for the wonderful presentation.
Thank you, sir. Thank you.
And excellent workup. And taken a lot of pain for investigating this patient. And also, most of the genetic studies are costly.
Yes,
I
sir.
just want to have one comment about the lipoatrophic diabetes.
Yes, sir.
The case which I have seen, one or two cases I have seen when I was in medical college,
yes,
where the lipid atrophy over the face and upper limb starts a little earlier.
Yes.
That is between the ages of 30 and 50.
Exactly.
Rather than at the 65, because, and it is very, very striking when you see the patient compare the upper segment and lower segment. That is my experience.
Right.
And here the age is a little higher.
Yeah.
And possibly it may be difficult to recognize, and it requires a clear clinical sense to identify, and also the exposure. You have to see the upper segment and lower segment very carefully, and only strike the clinician.
Yeah.
So I congratulate your observation and wonderful presentation.
Thank you, sir. I fully agree with you, sir. This may not be a typical case of monogenic lipoatrophy. This could even be an autoimmune or some other reasons may be there behind it, because it started actually with the insulin like injection site lipoatrophy. But simultaneously, it's not only was there in the insulin site, but also there in the distal part, like in breast. So there was simultaneous lipoatrophy both in the breast as well as at the local injection site. So this could be an insulin-induced immune-mediated lipoatrophy as well in this case. We don't know. So that's why I just don't know. But I just wanted to present a case of lipoatrophy in this along with this thing. That's why I just put it along with that. Next one, sir.
Second is there any total lipoatrophy also? Because not only partial, but there is a case with the total lipoatrophy also.
Exactly, sir. Lipoatrophy can be two types. One is familial and one is acquired. And even in the familial, it could be a generalized familial lipoatrophy and partial lipoatrophy as well. And even in the acquired also, you can get acquired is mostly acquired partial lipoatrophy, mostly. And if it is acquired. In the familial type, it could be both generalized as well as partial.
The problem is the cost of investigation, especially genetic studies. Yes. We should have some facility in our medical colleges to have these things. Then only we can. We may be missing some cases, and we may be failing to investigate also. Sometimes patient cannot afford, and patient may not be willing also. That is a problem. but
Yes.
most of the time patient escapes with insulin.
Yes.
Only thing we should be careful about recurrent hypoglycemia and sudden drop in blood sugar. That is the problem. Okay.
Yes. Hopefully in
Uh,
another 5 years or so, we'll see more centers doing the genetic testing, sir.
Yeah, our medical research unit in Calicut, they are doing the NGS, and we have applied for the specifically for the Modi.
Yeah.
They have to be funded by. They are doing all the NGS panel and all for
Panel.
other studies, all funded
Right.
studies. So
Right.
we have to
Rojit,
facilitate.
Rojit, why can't you give this topic to a PG student who is you can find
So
out
the
some of the
cost,
cases.
yeah, cost is we have applied for this screening
Grants.
in for the grant for the government, and we are waiting for the approval, but it's difficult to get. Anyway, it's a very interesting talk, and the high index of suspicion. We may be missing a lot of cases in our daily practice,
Yeah,
and
that's
this session will definitely help young generation to think about it and send the investigation. And the enthusiasm you have shown is excellent, sir.
Thank you, Rajit.
So, if any comments,
Matthew John was about to say something.
Matthew Jan, sir.
No, there's actually no specific comments. I think excellent presentation. No more
Thank you.
comments.
Thank you, Matthew.
Just one question, Suresh. Is there any this lipodystrophy? No.
Yeah.
Because we also see some cases we suspect it is lipodystrophy, but very difficult to prove it. Any method that other than means clinically, like someone will just you had a very clear MRI to show that difference. But any other methods, like should we image any imaging method where we can pick it up very clearly? Because many cases come, but then we just brush it under the carpet and keep going on.
MRI is the best thing because MRI will show fat levels as white shadows, bright shadows, usually. Like in contrast to the thing, and there will be usually symmetry, especially in the face. You can see symmetry, and if you do upper limbs also, you can see the same thing. Fat can be easily identified with MRI. So otherwise, that is leptin is the another thing, but leptin thing is that in partial lipodystrophy, leptin can be normal also. Normal. So unless generalized lipodystrophy, which you can clinically make out, you don't need leptin there. But in partial lipodystrophy, leptin may not help. But and it is costly too. So if it comes normal, you can't rule out lipodystrophy. So the only way is actually clinically visualize with your eyes. You make out, as Sir was telling, differentiate, like there will be discordance between the upper and lower things. Sometimes there will be specific lipid accumulation in one area, like in the buttocks or upper thigh, whereas loss of fat in the arms or something like that. Several specific areas of severe loss of fat that will make you suspect this thing. And if it is lasting for quite some time, and if MRI shows a typical rarefaction for fat, that is also, I think that is the only way we can diagnose it. Thank you, Matthew.
So we had a very good interaction also, and a lot of take-home message from this session. And thanks to all participants for attending this. And once again, thanks to our brilliant secretary for a brilliant presentation. And please do attend all Diabetic Crossroads, and every third Thursday we'll come up with good topics. Thank you.
Rojit, but for you, I wouldn't have presented. You insisted on presenting.
It has to reach more audience. Really.
I know. I didn't realize that it is so very important. So important.
Yeah. Thank you.
Thank you. Thank you. Thank you all.
Thank you. Good night.
You have published this article,
Sir, I'm writing that article actually.
Another article was published earlier.
That is it. I have published on other things like other cases, specific cases, case reports, and all these things. But the entire, the entire thing as a review article, I have not published. I am writing that review.
Individual cases you have published. I just
I have
read somewhere. Okay.
Yes, sir. I have published. That is, mine was MIDD. Largest series was mine in mining from India. Largest series from India.
One more suggestion, that Modi calculator is already existing. So in Indian scenario, you have few cases and a few variables you find out. You put that variables into that and make your own.
This evening,
so that in resource poor setting we can get more positivity.
Exactly.
Positive predictive value will be more when you do so that the cost effective. For the analysis.
Exactly. This evening I was actually trying to do that, looking at the clinical parameters which has got statistically significant relation with the MODI positive cases. I was trying to make out its predictability, like specificity and sensitivity for those clinical parameters to predict MODI. But I didn't get.
The problem is the number of cases. So we have to have.
No, Rojit, I'll tell you, if you go and search for monogenic diabetes studies, the studies published by institutes and all these things, only so many cases are there.
Oh.
Only as many cases are there as it's not too many cases of MODIs. Even yesterday.
We should have our own Indian calculator. So we may get more.
From the whole India, actually, Mohan sir actually collected cases from the entire country for a monogenic, team was a monogenic research group is there. It was a monogenic study group, National Monogenic Study Group. I'm also a member of that. He had around 59 cases from the entire country. Understood? Mine was the largest contribution from a single center. Mine was the largest single center contributing to his group. He has acknowledged that. That's why I'm telling. He acknowledged that thing. But that can happen sometimes because clinically you overlook it because you're too busy. And there is no definitely specific features that can actually give you a clue as to whether it is monogenic. Then you can't blame clinicians for missing it. Out of my curiosity and clinical interest, I just put some more focus on this thing and picked up. That is the only thing. Otherwise, everybody, even for me, we all would have otherwise missed cases.
Thank you, sir. Thank you. Good night.
Good night. Good night.
Good night.
Good night, sir. Thank you very much.